Hello and welcome to HealthTech Hour on UK Health Radio. My name is Steve Roost, and each week we bring you the best news, views and interviews with the leaders, clinicians, founders and CEOs who are changing the face of healthcare in the UK and beyond. I'm a founder and CEO of a health tech company myself, and I'm passionate about the people and companies who are changing the world. Before we get into it, as always, I want to thank everyone for listening. We're coming back after our little summer hollybobs, so it's good to be back in the studio, good to be back live. Would remind everyone to follow us on the socials, which is at HealthTech Hour, as well as follow the station, which is at UK Health Radio, just to stay on top of everything that's going on. So today's show is another, look, I love doing the show. Everyone knows that listens, I love doing the show. But today is another one of those shows where we're dealing with a concept or an entity that is part of the glue that holds the healthcare system together and helps us all get healthier. And there's a very good chance that a lot of people listening may not necessarily realize that this is going on and that this company is as important as this company is. So today we've got David Ezra, who is the founder and CEO of Vantage Health. Now, Vantage Health are dedicated to transforming the referral process and getting people the right care at the right time. What does that mean to you and to patients? What does that mean to all of us? Well, everyone's probably had a referral from a GP before to a hospital or a specialist or some other care pathway, some other person that they need to speak to from their GP. But what happens if you're referred to the wrong specialist? What happens if your GP didn't do all of the things that they were supposed to do before they referred you? What happens now in the post-pandemic world where elective care has been stopped, where it might be more difficult to get appointments? How does that all get handled? And then what you have to also understand is the NHS has said that this was prior to COVID, that if 40% of referrals are not removed, as in they need to reduce referrals by 40%, the NHS is at risk of collapse. So that is the problem that Vantage Health is trying to solve, or is solving at scale across the NHS, which is, I think is fascinating because it's an issue that faces all of us when we go to the GP and we get referred. It's a universal problem and they're providing a solution. So David, welcome to the show. How are you?
Yeah, I'm doing really, really well. Thank you for having me. Good.
So I ask everyone this, although now we're kind of out of the pandemic, hopefully, kind of touch wood, or at least for a little bit before it all kind of kicks off again, I'm sure. What's the mood in the camp like at your place? I know that you've had quite a crazy 12 months.
As an understatement. It's really positive. I mean, obviously, the pandemic has changed the world beyond recognition in many ways. And for companies such as us, it really has brought to the fore how important the solutions that we're providing are, and really motivated the team to be able to work at pace and with great enthusiasm to deliver very customized solutions to the NHS to make sure that they could manage what is a very desperate situation.
Yeah, we're going to jump into all of that because I know that look, you were obviously doing fantastic things prior to the pandemic, and there was obviously like I said in my intro, which actually came from the pre-production call that you and I had. The NHS has a problem with over referrals anyway prior to COVID. So your business was hugely valuable to the service then, and I think that might have become even more so as a result of the pandemic. We can jump into that in a bit. The show we do generally, as regular listeners will know, in 3 parts. So there's the origins part, which is how you guys, you and your team came to be doing everything that you're doing to change the world. The middle bit is all around what you are doing, and we can get into the nuts and bolts of it because, again, I think on a human level, on a basic level, everyone will understand the problems that you're trying to solve. But I don't think until you put it together and you look at the whole, you realize, like, oh my goodness, this is an enormous problem. So, and then the final bit is what might be in the future for Vantage Health. So first of all, just give me kind of some background on yourself and how did you end up moving into healthcare? Was it something that you always wanted to do, or how was that journey for you?
Wow. Well, about 16 years ago now. So I was in my university dorms.
Yeah.
And I was having a conversation with my cousin Adiel, really kind of looking at what our next steps were to do in life. I'm not one perhaps to go into a kind of conventional, much to the dismay of my family, I go to a conventional career, and just looking at how we could change the world, being very ambitious about how we could apply all the latest innovations, technologies to be able to do something really special. And we kind of settled on digital health. In particular, I guess it struck both Adi and I that the ability to move patient data, images, rather than the patients themselves in order to improve care could truly help a stretched NHS avoid so many of its problems, particularly around unnecessary hospital visits. So quite boldly, we set about starting Vantage. We had a very clear vision from the outset, and that was to optimize patient flow through innovation. We set ourselves a mission to deliver truly transformative solutions to improve healthcare services, and set a core set of values, essentially to learn, always understand how and where our solutions could have the most impact, collaborate, as in to always work closely with clinicians and stakeholders to customize our solutions to meet local needs, and to act, just really go for it. If we see an opportunity, really, really go for it. I guess it's hard to, I guess it would be easy to say that we always knew where we were going to end up. That's absolutely not the case. We made tons of mistakes, ran into loads of brick walls, but we really just had this feeling that there was something there, and through exploration we'd get to something that would be very special.
So look, I love the idea that the two of you and as undergrads are just sitting there trying to figure out how to change the world. So like, but did either of you have any experience of healthcare, health technology? Like how or what was that kind of decision tree that you went through to end up with we need to help transform the patient pathway to deliver better care? So I'm guessing you didn't immediately land on that. So like, how did that sort of how did that flow happen?
I guess really, the kind of the real genesis of this, I guess, was inspiration from another cousin of mine, Dr. Benjamin Angel, who sadly passed away at a young age of 26 from cystic fibrosis. But he, in his very short life, had achieved so much. He went to Cambridge, became a doctor, but was highly entrepreneurial. And his view was very much about how you could improve decision making by through technology. So I don't know if you remember the Palm pilots.
I do. That dates me, but I do.
Yeah, dates all of us. But essentially, he had created a program by where before any surgical procedures, you could see eminent surgeons across the world doing very, very specific procedures. Instead of looking at your books, you would look at the procedures, the videos. It was incredible. He won Young Entrepreneur of the Year, and a year before he passed, he was quite ill at that time. He gave Adi and I the time to go through some basic concepts about what would work, and we actually started off with concepts around telemedicine. So the idea of sharing images and data remote and to get remote diagnostics. So that was the kind of area that we cut our teeth on. And Benjamin's parents, after his passing, said, look, we want to help you on this endeavor. We want to invest in this. But as part of the investment that was in the company, a significant portion was put into his name, into the foundation. And I'm not going to spoil the story. So about 2 months ago, we were very, very delighted to say that we were acquired by NEC, and a significant amount of money went into into the trust, and so that his legacy would be honoured. And it was very, I guess, emotional for me to talk about it in that way. I don't want to get into that too much detail, but it was really very special for us.
I can imagine. And look, thank you for sharing what is obviously a very powerful kind of powerful story. And so was it from the beginning you felt almost sort of you'd been given a mission, and you needed to fulfill it?
Totally. And I guess I'll put it on to you. I mean, when you started up, I mean, how hard it is.
Yeah.
I
mean, yeah.
How did you find it when you first got involved in?
I mean, when we first started our company, sort of, I don't know, 2 or 3 years ago, we were in sort of smartphone. We are in smartphone-based diagnostics. So PopDoc allows you to test yourself for cardiovascular disease risk or diabetes risk using your smartphone and one of our proprietary lateral flow tests. And at the time, we were facing like questions from people like, we don't think people are going to prick their finger, and think like really basic stuff, and that you just couldn't argue your way past. There's not really a way that you can sort of get past that if someone just has a sort of a shutdown. Also, the our good friend Elizabeth Holmes, that story had just kind of broken in Bad Blood as well, and so that wasn't massively helpful at the time. So going out there with a sort of multiplex blood droplet of blood based diagnostic system on a smartphone was there was certainly some questions around that. I think for me, two of the way I view the world generally is that you never know when the bus is going to come around the corner, and you just don't know. I mean, two of my friends, very, very good friends, died before they were 32 or 33. And my father had a stroke that was pretty debilitating when he was 43. So I sort of, from a really young age, was really aware of the fragility of what we have, and that within an instant it could be snatched away. And so if you wanted to make an impact on the world, then there's no better day than today to just keep going at it. And it's tough. And I think that what I will say is, having done this show now for nearly a year and spoken to probably 30 or 40 founders or clinicians, leaders, CEOs, generally speaking, everyone in health tech has a mission. And a lot of the time that mission has a personal kind of story behind it, which I don't necessarily think is the same with a lot of other industries. And I think it's extremely inspirational, and having that mission, I believe, I don't know what you think, but to kind of follow back of a bit of a ramble of an answer to your question, having that mission gets you through the tough times, because, and there are going to be tough times. Like and health tech is one of the toughest businesses to get into because it's obviously so highly regulated. There's all kinds of, also, if your product doesn't work, it's not like, I bought some dog food on the dog food marketplace and it was like 3 days late and my dog didn't like it. It's sort of, well, if your product doesn't work, that might mean someone could die or be injured or all kinds of really, really negative consequences. So, I would say having a mission helps, but I don't know what you think.
100%. And as I said, from Benjamin, it really was this sense of like, you can achieve. It doesn't matter what's in front of you. You can really achieve, and you should push the boundaries to do what's right. I mean, those nights when Adi and I remember sleeping in cars and going to all ends of the country, trying to get feedback from clinicians, trying to engage with stakeholders and managers, trying to find out what made them tick. It really, you're right, it's just that mission. It just really felt as if this is what we're meant to do. And I guess failure wasn't really an option. I didn't know what success was necessarily going to look like, but I certainly knew that giving up was not an option. And I guess going back to more about what we were looking at is that it came increasingly apparent to us that the NHS were investing millions of pounds in developing referral pathways to try and manage demand effectively, particularly on secondary care services. Yet despite all this work, GP compliance with these guidelines was limited. And as a result, I think what what we were seeing was that these referral management centers were being set up and down the country in order to vet GP referrals and direct them to the correct services.
Okay.
And I remember Adi and I, we visited a site in the south, and literally we were in shock. We saw 25 people in a room sifting through mountains of paperwork and documents on their computers, all this staff and processes with, you know, when we speak to the commissioners, they were telling us that this was recurring costs in the millions of pounds. And this was just to manage 35 practices. And for context, there are over 10,000 practices in the country. So it was that kind of light bulb moment, knowing that this was irrational, if not insane.
Yeah.
You know, we were aware that lots of other companies were offering decision support systems to help GPs follow pathways.
Okay.
Yet it was clear that this weren't being followed. They were simply being regarded as repositories of information, and GPs had no time to even look at these in their workflow. Right. And the presence of dozens of these referral management centers were testament to that. So I guess in a nutshell, we felt we could do better. We felt that through smart integration, using structured data, algorithms, we could operationalize pathways, we could automate triage, we could eliminate bureaucracy. Yeah. And effectively, our dream was that clinicians could refer patients in under 60 seconds to the right provider the first time, a true care navigator.
Which I think is incredible. And we'll jump into that in a bit, but just before we do, I want to just, again, because I know we've got our listeners are really educated about this, but just let's get some terminology out of the way. So sure. When we talk about like a pathway, what do you mean by a pathway? Just give us an example, really simple.
Okay, so let's say you've got a medical specialty. Let's take, for example, cardiology.
Okay.
And cardiology is quite a broad area, of course, specialty. And within cardiology, you will have different subsects. So, for example, heart failure. So people might be referred for heart failure. And therefore, there is a pathway for treatment of patients or management of patients with heart failure.
Okay.
So, for example, if a patient has suspected heart failure, the typical things to do a particular set of tests, BNP. You would ideally do an echocardiogram.
Okay.
And based on the outcome of those investigations, you'd be able to ascertain the level of severity. And okay. That's essentially what the pathway is. And
so I mean, we've been through this on our side of things and with POC and cardiovascular disease and stuff, but sure. It's the way I understand it, which is similar to what you just said, is effectively the gut for any given problem, issue, condition, you know, or sector, it effectively kind of dictates or suggests what the clinician should do in Correct. That instance, yeah. Whether it's tests, whether it's, you know, further investigation, whether it's, I don't know, emergency action or whatever it happens to be, but it's almost like the Bible, for want of a better word, of what should be done in any given situation. Is that fair?
Correct. And look, medicine isn't always so binary. You know, there's a lot of grey. However, there are established. I said, the NHS is fantastic at that. They have so much evidence around conditions about how to manage it, what the best outcomes are. The problem is that generalists, whether in GP practice, optometry practice, dental practices, they just can't know everything, and they can't. You know, it's just impossible to do that. And they're gatekeeping, you know, tens of patients each day coming into them personally and having to, you know, diagnose them and then be able to understand what to do next. And so how do we get, and this is the challenge, how do we get all that institutional knowledge, and then implant it into the brain of every single clinician? And it's not just clinical, it's also operational. So in terms of each area of the country, so we talk about some terminology. So GP practice tends to be in clinical commissioning groups. And each of these clinical commissioning groups may have commissioned various different services that are bespoke to their area. So you might
Yeah.
have a community cardiology service, you might have a community.
You might have mental health, you might have specific mental health services, or specific
Correct.
weight loss services, or diabetes treatment services, or all these different kinds of things.
Precisely. And there's criteria that need to be met to get into those services that change throughout. So if you're a locum GP, you might have no idea about what is running locally if you're just coming up turning there. And your default position then is, I know I can't deal with this patient, I have to send this patient to hospital.
Yeah.
And therein lies the issue.
Well, that's a great, we have to break for some commercials from our very trusted and valued partners. And then we'll come back and we'll pick straight up off there, because that is a very good segue into your solution and how it can help.
Lovely.
Vitamin C supplements. Usually only a small proportion of vitamin C actually reaches your cells and has a positive effect. Whereas the high absorption levels of Goldman Laboratories liposomal vitamin C will maintain optimal vitamin C levels in your body and strengthen your immune system. Now get 10% off when you choose Goldman Laboratories liposomal vitamin C capsules. Just quote 10 off at goldmanlaboratories.com. Laser, a whole new CE-approved medical device for the effective treatment of pain, is now available in the UK. The results of a double-blind trial have shown that Cure Laser offers a significant reduction in pain compared to placebo group. To get your special Cure offer now, call 0808 501 5122 or Google Radio Pro London. Cure Laser.
Hello. Okay, great. Welcome back. We are talking to David Ezra, the founder of Vantage Health. And so, David, just before we went to the commercials, we were talking about, you were kind of explaining about the pathways and all of this different knowledge and issues that GPs face, and the sort of almost like, it sounds like it's almost an impossible task that they have, given the scale of information that they need to consume, the volume of patients that they have to deal with. And so, how did all of those problems that we've talked about kind of coalesce into the solution that you developed?
So actually the first opportunity, so let's just take a tiny step back. So when, that kind of light bulb moment where we knew we could develop all these using integration, structured data and all that stuff, was that we set about from the bottom up, building our platform, and the engine behind it that could handle all these complex rules to be able to manage what's to be customized, what's responsive to local needs. And we call the platform Rego. So you hear Rego a couple of times. That's the platform. Yep. And the first opportunity to showcase Rego actually was for dental. So dental referrals shared many of the same problems as GPs, but had one further issue. It was almost entirely paper-based.
Okay.
And so
that's insane.
Yeah, it's crazy. We actually did a very small kind of proof of concept in Northwest London. But it wasn't until the southeast of England, that covered Kent, Surrey and Sussex, really looked at this and were incredibly pioneering and said, actually, we need to bring AI-powered triage to the NHS.
And when was this? How long ago was this? Was it quite an early call?
Well, the company, I guess, went through a number of different iterations, and we had lots of very good proof of concepts, but it wasn't really until 2014, really, that we actually got any had commercial success, and that was our first commercial success. It was quite a significant contract, but essentially what we could prove from day one of the implementation across, I think, must have been 600 dental practices, about 20 hospitals, hundreds of providers, was, from day one, we could automatically validate referrals against criteria. We didn't need mail intervention. We didn't need rooms full of people. Wow. And this large scale rollout demonstrated the system's scalability and our ability, I guess, the company's ability to handle complex multi-organizational projects across a large geographic footprint.
Yeah.
I mean, from day one,
and so like when you just to, oh sorry, carry on, finish.
No, just to say from day one, what was unbelievable was that they saved I think £2-3 million from eliminating several referral management centers across the area.
It's amazing.
So essentially, we had proved, that true digital transformation.
So with this referral management systems, presumably were there, like you said, to kind of vet referrals, presumably to assess their validity, accuracy, completeness, right? Do they have all of the information that they require? What are some of those problems that specifically with referrals, like I spoke about in the top of the show, we talked about it in our pre-production call, like there are some pretty basic things that sometimes don't happen or should happen. And that's a lot of the time, the kind of the problems in the system that you guys look at.
Yeah, I think they could be split into various different sections. So you've got your basically administrative element. So is all the patient demographic information there? So the contact details. And for dental, that's a huge problem prior to Rego, because they didn't have access to the patient's NHS numbers unless the patient gave it to them. Do you know your NHS number off by heart?
No, I don't. I imagine a lot more people do thanks to COVID, but no, I don't.
So the issue was for dentists is that they didn't have the NHS number. If it went to a hospital, the hospital wouldn't accept it because they need an NHS number to go and process the referral.
Oh,
so via our system, we could automatically identify the NHS number of the patient and then go a step further, because then the next level of administrative is this patient being referred to the correct service based on the location that they're in. Now, and I don't just mean, and this is super complex, I don't want to get too much detail, but in dental world, you might go to a dentist in London, in North London, for example, but your GP is registered in South London. And now the criteria for the dentist was actually not based on which dental practice you go to, or even where you live. It's where your GP practice is allocated with. So we were able to piece all that information together from an administrative level. From a clinical level, what's required is, you've got two elements to that. You've got completeness, as you said, so make sure that all the mandatory information is put in. If you do it through a paper-based process, or even through a Word document on a computer that you could upload, you wouldn't be able to check whether all that information is being put in. So, and that has a profound impact on the clinician, the other side, because they're not doing it to be difficult. They're saying, well, if I don't have this information, how can I prioritize this patient?
Yeah.
and then attached to that, we felt we could build in the criteria straight away to say, if this, then this would happen. So if it's this specific tooth, then you would need to have these reasons to go to the next level. And if you consider that the patient's medical history is this, then that would have another impact. And it's kind of if this, if that kind of logic that we built in to be able to go and operationalize those pathways, so to increase the accuracy. And there's the last element is really about supplementary information that's really useful. So if I pick on dental because it was the first area we started with, and learning from our work in dermatology, images are crucial. So in dental world, it was quite crazy that at the dentist side, they had these amazing X-rays. They were digital, but because there was no electronic referral service, they would have to don't laugh. They would have to get these amazing digital images, print them out.
Good call.
and then attach them to the other bits of paper and then send them off. Now, of
Right.
course, when someone looks at a paper copy of a digital image, they're like, hold on, what is this? So the fact that
one could say that the resolution of that digital image might be somewhat negatively impacted by the fact that it's come out of an office jet.
Yes, exactly. So the fact that we could have all those images attached onto the system was great, and that we could go a step further as well is that we developed an app, again 2014, that enabled clinicians to take images of patients and to automatically upload them from their phone onto the system as well. We've now actually expanded that to patients could do that from home. They're given a pin, they could send images. So for ulcers and cysts, whatever it is, and that could help hugely and be able to prioritize patients, identify which ones need to be referred and not referred.
Cool. And I know this is going to seem like a really basic question, so I apologize, but is it possible to sort of try and like quantify, well, quantify is probably the wrong word, but sort of expand on why does this actually matter to patients or the users of the healthcare system? Like how does that flow down to an improved experience for them?
I think the best way of doing that is basically on personal anecdotal evidence. I mean, you know, we're all patients, and we all want you know, when we're concerned about our health, we want to be managed quickly, efficiently, with minimal fuss. And I've had, you know, from my personal experience, where I was referred for an issue. Don't have to necessarily disclose everyone.
Yeah, you don't need to share.
I won't necessarily share it, but essentially I turned up to hospital, and I was had a very nice chat with the consultant for about 10 minutes, and the consultant said, yeah, you know, can you it's really good to see you, David. I think everything will be fine, but you know, can you go and get you need to get a couple of bloods done, and you need an ultrasound as well. So I was like, okay, is there anything else you can tell me? And he goes, well, I can't really do anything until I get those tests back. And it was like, yeah. And I'd waited 14 weeks to go and see this consultant.
Oh, wow.
And so now I'd wasted his time, and I'd taken time out of work. Yeah. And I'd worried, you know, I had all that worry through that period of time, when actually what could have happened was that at point of referral, I could have had those bloods done, have had them back the same next day. It would have been, you know, referred for an ultrasound, which would again maybe taken a week or so, you know, through one of the local community services. And what the consultant was saying to me is, actually, had I had that information without even seeing you, I could have told you what to do next. So, right, you know, and I'm thinking I'm a, you know, a fit, relatively young guy, not as young as I was, but you know, imagine that for elderly patients. Yeah. Imagine that for you know, for young people who have got issues about access, getting into places, and mental health issues. You know, what are we? This system it needs fixing. Yeah, I think that's really powerful. I mean, that kind of idea of, if that you've waited 10, 12, 14 weeks to see a consultant, a specialist for this issue, and they say, oh, actually, I can't, I'm really sorry, I can't tell you what I think until I get these 2 or 3 other bits of information. It's sort of logical that within that 14-week period, surely you could have been able to get that information, or the system could have enabled you to get that information to the consultant. Yeah, I mean, what's more frightening is now that example was about 5-6 years ago. The waiting list now, I mean, you'll be lucky to see in many cases to see anyone within a year. I mean, it's, you know, for anything, it's huge backlogs. Obviously, the closing of elective care during the pandemic, and it's being slowly opened up, you know, is really frightening. Right. You know, whether you got a routine condition that needs to be looked at, or whether you've got an urgent, or God forbid, a cancer, you know, to be able to, we need to fix this. Yeah. And so specifically about waiting lists and those issues, which I think have obviously been pretty widespread
but pretty widespread in terms of their airing in the media and things like that. I think everyone's pretty aware of them. How exactly are you planning, or are you already implementing your solution to try and address those specific issues?
Okay, so we, at the core of what we do, is to be able to direct the patients to the right place at the right time. It sounds quite tripe, and I know that lots of people say they do that, and lots of people are doing those things in various different guises. Where our angle comes in is to say, right, let's firstly identify whether this patient needs a referral at all. Can we upfront give the GP the knowledge to be able to manage that patient in primary care? Okay, so that might take care of maybe 10, maybe 20% of referrals that would have gone previously. Now, okay, they might need some additional care. So can that care be provided in a service outside of the hospital? Because there's lots of community services being set up, lots of supporting services to do that, whether it's mental health, whether it's dermatology, with cardiology. There's lots of services that have been set up. Can we then say, right, okay, this has met the criteria for referral, but can be managed in those settings? Or can it have, or does it need diagnostics first? Do we need a set of diagnostics before it goes any further? Mm-hmm. And then the level comes, actually, maybe the patient does need to be seen by a consultant, but actually, can we make sure those investigations are done up front to enable the consultant to do a virtual consultation?
Yeah.
Because if you have all the tools in front of you, all the information in front of you, the consultant can make that opinion remotely. Right. So can we enable that to happen? Can we identify patients who might be suitable for potentially for group-led clinics? So not necessarily coming into for a one-on-one. Can we identify cohorts of patients that can come in? Let's say, for example, those who suffer from long-term chronic conditions, can they come in to a session with a consultant, one consultant for 2 hours, and get 20, 30 people in a room? Bit difficult now necessarily with COVID, but hopefully when those things come up. But the principle still applies, that if you go through that funnel, we'll be able to actually then only get those patients that need to go to hospital down, quite significantly. And even at the work that we did running at pace across Northwest London, we've managed to see a huge impact of, we did enhanced advice and guidance, and for Hillingdon, Harrow, Brent and Ealing, and connecting the hospital trust there. And we've seen 30-40% of the cases going through the system managed in primary care. Now, notwithstanding that might be a slight disproportionately higher number due to COVID and people really taking a view saying, well, we have to manage as much as we can in primary care, but that's still incredibly impressive.
Really high.
And that's without a lot of the intelligence that we're building in for each of the pathways. That was a very much a system run at pace around advice and guidance. So the full navigator solution will have a positively drastic outcome.
Good. Well, look, on that note, we have to do another break for a couple of minutes just for some adverts, and then we will come back, and there's a few things I want to pick up with you as we enter the final part of the show. So we will be back in 1 second.
Scalar light is the quantum energy emitted from the universe, from the sun and stars. Now, Tom Palladino, a humanitarian and scalar light researcher, has created the world's only scalar light healing system. A system that can bring long-distance healing and wellness to humans, pets, and plants via a photograph. Get your free 15-day trial now at scalarlight.com, or click on the Scalar Light banner on the UK Health Radio website. Shields like masks are top of mind right now, but did you know you have inner armor working constantly to protect you from pathogens? Thriving is your immune system. Our gut triggers the body's natural ability to support gut strength all year long, so your immune system can protect you when you need it the most. How are you treating your inner armor? Visit uk.ionbiome.com to learn more. Ion Gut. Protect what protects you.
All right, welcome back, everyone. I'm going to the final part of today's Health Tech Hour with David Ezra from Vantage Health. So, David, just before we spoke, we were talking about how you guys are, Vantage Health and the Rego system, are trying to effectively address the waiting list issue by allowing more people to be treated in primary care, GP services. So, which I think is phenomenal. I think what I'd like to understand a little bit is what does a GP, because when you go to a GP, they obviously have their computer in front of them, they talk to you, they tap away, they do whatever they're going to do. How does your solution sort of, well, what is their experience of your solution? Do they have to sort of remember to log in somewhere else to check what Rego thinks, or is it sort of integrated, or how does that sort of play out?
So it was very important to us, and we took a lot of advice from clinicians to make sure that the system runs as incognito as possible. So with as little interaction as possible. We're acutely aware that GPs have a finite time to be able to, they've got so much to do. So we need to make this seamless within their workflow. So the system is launched directly from each of their record systems, whether it's EMIS, Vision System 1, as by the way, all other systems, whether it's Optom solutions or dental solutions, but sticking to the GPs. What we wanted to do is draw all the information they've got already in their systems. They're not double keying. So because things are coded, because outcomes are coded within there, whether it's lab results, whether it's conditions, encounters, whatever it is, we were able to bring them into Rego and to run algorithms against that. So essentially all they need to do is really just confirm where they, that they're happy to proceed. It sounds a bit glib, but essentially within 2 or 3 clicks of they're able to proceed. And because we integrate with ERS, the National Electronic Referral Service, we were the first organization to do that within primary care as partners of NHS Digital, who I have to say been fantastic and working with us to be able to present the ERS clinics, to be able to provide a UBRN, a unique booking reference number, to the patient on the same screen within seconds. So that was crucial. The dream was, can we get this to be undertaken in less than 60 seconds with as minimal interventions as possible? And what GPs are telling us is, this, whereas beforehand they never really did their own referrals because it was too cumbersome, it was too lengthy. They would have outsourced this to their admin teams. They're able to do this with the patient in front of them and be done with it. And it's been extremely powerful in that respect.
That makes a lot of sense. And so just picking up on that, overall, what has the feedback been from GPs or commissioning groups, or what's the kind of the qualitative feedback, and then also what sort of impact have you been able to measure that you've had?
I think the fact is that you will never get a consensus from everyone to say, oh, it's a tremendous system. We're acutely aware there are things that can be improved on it, and we are improving elements on it. So from a user perspective, listening to what they want. So and sometimes hard, they say, 2 doctors, 20 opinions, we have to respect what they're saying to us and make sure we can tailor the solution so it's constantly reflecting what they need. But on the whole, and through the surveys we put out, we've got incredibly high levels of satisfaction across primary care, high user acceptability. And look, quite frankly, if they didn't like using it, we wouldn't have the adoption rates we have. Over 98% from day one. You know, Hillingdon, for example, is the highest using highest CCG, using advice and guidance across the whole of the country, and that's testament to the usability and ease of use of Rego. So we're very proud of that. But not to get complacent, as I said, we're always making sure we're improving. From the hospital side or from specialist side, it's such a game changer for them, really optimizing their time. It's coming to a state that actually they won't need to vet any referrals because they trust the algorithms. Right. So that, you know, it goes directly to be booked, and they'll see the patient in the clinic. So that has a massive impact. A couple of nice examples, actually, you said about in the quantitative stuff. We did some really nice work. We're doing some really nice work, rather, in Suffolk. At Ipswich Hospital has been nominated by HSJ for an award for the work they're doing around our dermatology pathways and being able to downgrade 2-week wait referrals via Rego. And I think within the 3-month study, they had managed to reduce 50% of the 2-week wait referrals, downgrade them into routine referrals, which enable them to free up time to go and see those patients that needed to wait. So full credit to the commissioning team out there. They've been amazing. Peter Holloway and company have been fantastic. Libby, the consultant in the hospital, the name escaped me. Apologies, Libby, if you're listening. But it's through their hard work that's been able to be delivered. But obviously, we're very proud to be able to support that and had a very, very positive impact.
So just to break that down, so I understand it. Within the particular dermatology specialty, there was an urgent 2-week, there's sort of an urgent 2-week waiting list, which is that if you've got a particular issue, potentially you have to be seen within 2 weeks. I'm guessing, is that like skin cancer related?
Yes.
I would suspect. Okay. Your system managed to determine that half of that list actually could be seen in a routine manner, which then freed up that half of the list.
Correct.
For more people who definitely needed to be seen in 2 weeks.
Correct.
Right. That's phenomenal. And if your system hadn't have been used, what were the issues that meant that those people who were routine had ended up on that list? Why had that happened?
I think it's purely because, you know, again, GPs are not specialists. They won't know. Right. You know, if you look at a mole, or, you know, you might think, oh, that's a bit worrying, and they'll make a decision based on what their clinical knowledge is, and it's not about being right or wrong. It's just they don't have as much experience as a consultant of 20 years looking at these images and being able to understand it. So we help guide them through the criteria level, and the consultants can then also look at this and then make an opinion and give it, and within you know, minutes be able to turn around and say, actually, this can be managed in primary care.
That's fantastic.
So, yeah.
And is that how do you believe that sort of 50% reduction, you know, I know you mentioned previously 40%, is that at the moment what you think generally is achievable with your system in most areas? Is that sort of the level you work? Because if so, that's enormous across, you know, that's kind of a crazy high.
Well, actually, in dermatology, we've seen up to 72% of referrals managed in primary care.
Wow.
But most that's for routine cases being downgraded to be managed in primary care. But no, certainly it varies. It does vary. I mean, some specialties will be high, and some of them will be a lot lower. Some surgical ones, it depends. So I would say that across the board, we're looking at between, you know, conservatively 25 to 30% impact on the waiting list, and if we can achieve that, that'd be phenomenal.
Yeah, that's game changing, right? I mean, what was it? You said the NHS was targeting 30 to 40% of reductions in referrals, like across the board, like in total, which, you know, you're doing the lion's share of that potentially all by yourselves, which is pretty amazing.
Yeah, Yes, I would again just
Potentially.
potentially, no, but I'll also say that that is very much contingent as well on the collaboration we have locally, and we've seen that we have lots of interest in our solution on a daily basis, bombarded with people looking to take this further, and it's one thing being interested, and the other thing being able to give the time to be able to make sure that the system is customized accordingly to what they need.
Yeah.
And it's not a huge amount of work, but it is a commitment, and it's through that commitment that you see the real change. I mean, certain areas we work with are great, but see less of that kind of outcome because of the amount of time they can put into it, and those who put more time into it see the greater return. So it's about as much as you put into Rego, you'll get out of it. But the good thing is, once it's set up, it really runs itself. I mean,
that's fantastic. Yeah, I think that's fantastic. So what's next for you guys over the next 12 to 18 months?
So yeah, as I alluded to right from the beginning, we're very lucky to be acquired by NEC, which formerly Northgate Public Services, a fantastic organisation that we were so happy to be part of. They have a lot of experience across public health, across a number of sectors, and going to really help us, take what we've done and be able to make it, really, really scalable. Our bandwidth was relatively limited. When we were, up to 2 months ago, we could only take on a certain amount of contracts, but now we have the ability to take on the world. So what's next is to really focus on delivering as the NHS tries to get out of the pandemic and through the pandemic, working with ICSs, integrated care systems, to work with as many as we can to be able to support them and deliver solutions at pace. We've got some really exciting projects coming up along that and along those lines. So we are really, really excited.
Good. And have you seen, I mean, if it wasn't for services like yours, what do you think would be happening? I mean, do you think it was sort of inevitable that at some point someone would be doing what you're doing, but because otherwise that we would still be stuck with rooms full of people checking stuff by hand? Or like what does the alternative look like is what I'm sort of getting at here, I guess. Because I know like 16 years ago when you first came up with the idea, there were rooms of people doing paper, but is that still the alternative to your system? Or
I think there are lots of people doing various different bits of the pathway to try and fix of the service to try and fix things. At the moment, I haven't seen anyone try to do the whole lot as what we're doing. That's not to say that someone great isn't out there and going to do that, or might be inspired by this talk and want to be a competitor of ours and do that. That could be there. But I think the alternatives are pretty grim in terms of, if you don't do something like this, then particularly the trust gets swelled, the demand and the trust really swells. The manpower there is stretched, and ultimately the patient suffers. And I just don't think that's acceptable. It's truly unacceptable. And we have to use technology such as ours to go and make a difference. And there will be, unfortunately, still areas, I'm sure, for the next couple of years, who just won't commission service at this for various different reasons, and they'll be still stuck with manual processes, and unfortunately that will disadvantage their patients. Yeah,
I think that's pretty obvious. And I mean, like you say, there might be various reasons why they maintain those legacy sort of manual services. It might, I would imagine, though, in the NHS there's probably lots of different explanations for those that are complex and things like that. But I don't know. I mean, based on, as a sort of a lay person looking at this, I don't see how this type of technology and this type of approach doesn't get rolled out as standard over the next 5 to 10 years. I find now, whether, look, I'd love to think that you guys will be leading the charge and own the category, but even if you're not, and I really hope you do, but I just don't see in 10 years time how this isn't the standard, right? I mean,
100%. A little football anecdote I should tell you is that one of our investors right from the beginning was Arsene Wenger. The Arsenal manager. I'm a big Spurs fan, but you know, even as an Arsenal man, he had some really great vision. To be fair, and when he and they always said Arsenal knows best, and I think in fairness in this case he did. I mean, I think when he looked at getting involved in the organisation, he said, "Look, I'm not sure whether you guys are going to be the ones to do this, but I want to support this because I believe whether it's you or anybody else, this is the way forward." And that was 16 years ago. And Arsene, if you're listening somewhere, you are right. And this is the way forward. And you have helped make a big difference. So, yeah.
Good stuff. Well, look, I think on that note, it's worthwhile trying to sort of wrap up a bit, because I think how can you can't really top that as a way to end the show. So, David, look, thank you very much for coming on the show and telling us about Vantage Health. If there are any kind of healthcare professionals out there that want to learn more, where do they go? How do they find you?
Just the website, vantage.health.
Okay, very simple. And yeah, I mean, look, I think the next 12 to 18 months is going to be, I mean, you are at the vanguard of this, so very exciting space. And look, I wish you all the best. It's been inspirational to talk to you, and it's been great to have you on the show.
Thank you so much.
Good. And look, thanks to everyone for listening, and we will be back again next week. Thank you, everyone.